then it really helps you in pharmacology. And one other thing about these next set of lecture notes from me, and also the opioids that I will teach you in 2 weeks, is that you're going to have transcripts provided to you. Okay, so if you look on this side, there'll be transcripts there. So I won't say probably everything in front of you, but if you have a question and you're studying this information, you can look to the transcript and hopefully the answer will be there. Okay? You're responsible for whatever information you see on these slides. And we've spent a lot of time trying to grill them down a little bit. I feel very sorry for the student because about 7 years ago we decided to do these transcripts, and I had a resident out there who was trying to type what I was saying. I felt very sorry for that young lady, but she did a pretty doggone good job. So that helps. That's good for you guys. So first hour today, we're going to do autonomic pharmacology. We're going to take a look at the adrenergic side. That will keep us into the second hour, and then the third hour we'll do cholinergics. Cholinergics is much simpler in veterinary medicine, and so we'll kind of focus on that. But again, if you have your model drug list, go ahead and pull it out and have it next to you, or have it on your computer in some way that you can kind of take a peek at it if you need to. One more housekeeping detail before I forget. This week, I will cover this information with you on the autonomic side. Dr. Booth will join you next week for the beginning of cardiovascular pharm. Again, cardiovascular pharm, because we're going through it, we're a few lectures ahead of you guys right now over at Auburn. It's a tough concept, and I say that not to scare you, but to prepare you. Okay, so as you look at it, I think the challenge always for the students is not the drug side of what you're going to see here today, or the drug side of what you'll see next week. What will be a tough thing is if you can't pull that physiology back. Does everybody follow me? If you can't get the action potential of the heart, and that doesn't come back to you, then you may just need to step back a little bit. Dr. Booth will do a good job of doing some physiology review for you, okay? So usually when I come into class and I open up with a group of drugs like I'm going to do today, I will take you back to physiology for a brief few minutes, okay? Brief few minutes. It'll be a little bit longer today because the physiology here is a little bit more detailed, but I'll walk you back into that. I'll say, this is what you have naturally in the body, and now we're going to lay drugs on top of that. And all this, bless you. In this month and a half that you guys and I have been together, and I really enjoyed that time, we've really laid the foundation for that, okay? Because remember, the drugs have made it to where they're going. They're going to interact with an agonist, with the receptors you're going to see here in just a minute. And then they're going to produce a response. Okay, so that's kind of where we are in this class. But now we need to get away from drug A and drug B and talk about specific agents. Okay, talk about specific agents. So I just want to say that as a word of encouragement to you. Not anything to scare you, but just to kind of, again, prepare you for this. Okay, so as I've totally scared the whole class now, we'll go forward. Okay, autonomic pharmacology. This is where we begin. Okay, our drug, and again, drugs 6 through 16 on your model drug list as they appear here. This is what you learned in physiology last year. We split the system in half, right? You see the parasympathetic side and the sympathetic side. What I want to encourage you to think about this morning as we look at both sides of this. Normally I lecture on one, then I come back a couple of days later and lecture on the other half. But as we look at both sides of this pathway, I want you to remember these responses which occur. And I really like this chart because in your body right now you have these responses right here occurring to varying degrees. You remember this old sympathetic on the right-hand side here is more a fight or flight response, and then your parasympathetic on the left is more of a rest and digest type of system, right? Well, remember in your body right now, you have events going on there with neurotransmitters. Remember good old acetylcholine on the parasympathetic side. You got norepi, dopamine over here on the right side, doing things in your body right now. So here's the deal. We need to revisit what those events are and then begin the process of using those compounds, maybe as drugs also, but introducing some new agents as well. So for all of these slides, these lecture series coming up, because we are now embarking on specific drug therapy, there will be learning outcomes associated with each lecture. And those learning outcomes are real important for you. And you guys, we've been together now again a month and a half. You guys know how I work. when I come into class and I teach you specific things, I really like for the end of that hour, in our case, the end of 3 hours, I guess, for us to kind of accomplish a certain set of goals, okay? Usually I tell them to you, but this morning, you actually see them right in front of you, okay? These are specific learning outcomes. This is just for this first hour and a half or so. So what does it look like? Well, we want to compare the physiological functions of the sympathetic and parasympathetic nervous system. I mentioned that to you. That's, again, kind of what we're going to kick it off with here at the very beginning. We're then going to describe the synthesis and degradation of catecholamines. We're going to talk about catecholamines because you guys are actually going to utilize them as drugs, certain ones of them. So we'll talk about them first. We're going to define this role of receptors, go back to the physiology, then say, okay, what ligand are we talking about? What ligand are we targeting? Okay, remember pharmacodynamics, it's a receptor, right? So which receptor are you targeting? Then we're going to identify the clinical situations that you guys are going to use these drugs. Why do you want to use them? Okay? And then we're going to differentiate a compound called ace-promazine. You guys have all probably heard of ace-promazine, kind of a major tranquilizer type of compound. There's a lot of effects in the body. What I would call a very dirty drug, because it does a lot of things, not really all that specific, but we'll talk about that at the very end of this hour as well, okay? Not from its behavior modifying point of view, but from some other things that that drug does. So if you can walk with me through this first lecture, and we're going to have 2 sets of learning outcomes this morning, you guys will be in great shape. So, again, every time I come up with a list of drugs for you guys, it'll be opioids in a couple of weeks. I'll walk you back through pain. I'll show you the physiology of pain. So this morning, as I start off our lecture series, we're going to talk about the physiology right here, okay? The so-called balancing systems of the parasympathetic and the sympathetic nervous system. And again, you see them on the slide here. They were on the title slide as well. But in order for us to get our discussion started, you have to think, first of all, okay, in the body, you know, when I talk about pharmacology, we're typically talking about exogenous ligands. A ligand that you administer outside, right, that you put into the body. But what I want to caution you about tomorrow, at least get you to think about, first of all, is that your body right now, has endogenous ligands, okay, that are regulating these events, okay? And you see on the sympathetic side, I've already mentioned this to you, you have norepi being a major endogenous regulator right now, okay? On the parasympathetic side, which we'll get to again in the last hour, you have acetylcholine being the major regulator, okay? And again, we're going to focus on sympathetic first. It is definitely the more challenging of the two, and it is the fight or flight side of this. You'll notice that on the cardiovascular side over here, all of the events from the sympathetic side are designed to promote this fight or flight response. If you look over here to the right-hand side on the cardiovascular, you will see that the heart itself, you're going to see an acceleration because you need that, right, for your fight or flight response. The gastrointestinal side over here, well, you know, it's kind of going to back up just a little bit because you don't really need that going on as much as you do need your heart to kind of speed things along as you go through this. On the urinary side over here, if you just look down here, you see a stimulation overall with the kidneys and how they work. And on the ocular side as well, what happens to the eye when you have a sympathetic response? When you're having a fight or flight response, what happens? Yeah, it opens so you can see everything, right? And you see that dilation. We will refer to it in here as a mydriasis, okay, a mydriasis. So what I want you to remember is all of these things are going on in a fight or flight response. If I tell you that a drug is a sympathomimetic drug, okay, what you should think in your head is that drug mimics that system, right? It mimics that system. So if I ever tell you, if I just walked into class, we only have this slide today, and I say, hey, this drug is a sympathomimetic drug, you'd be thinking, hey, it's going to do things like norepinephrine does in the body, right? It's going to act like that drug. So that's the reason at the bottom right here I wrote drugs agonists. But I'm going to tell you about a group of drugs at the end of this lecture that are antagonists. Remember, your agonists have affinity and efficacy, right? They do something. Your antagonists only have the affinity, right? Only have the affinity. And remember, Selectivity right here is important. Most drugs, as I've told you, are going to go through that journey, and it's still amazing to me. They find that specific receptor, they interact with it. It's very important, okay? Very important. That's going to occur here as well, but you'll find at the very end here that ace-promazine is an example of a compound that's not quite like that. Not quite like that. Yes, ma'am?
Just to clarify, the sympathomimetic
Sympathomimetic, yes, it's hard to say.
mimics the sympathetic?
It does.
Okay.
It absolutely does. So, if I tell you a drug is, here's the terminology, and I'll use various terminology for you, so thank you for bringing that up. I will call this group of drugs sympathomimetic drugs. Sometimes I will call them adrenergic agonists. Is that the same thing? Mm-hmm. It absolutely is. Okay, absolutely is. I'll flip those names back and forth. But I'm very much like her. I can't say sympathomimetic more than a couple times in a lecture, so from this point forward, maybe we'll call them adrenergic agonists. Okay? Okay? The flip side of that, the cholinergic side, would be cholinergic agonist, right? Or parasympathomimetic. That's way too hard. Okay? Okay, so here's your first group of agents. We haven't gotten too far into it, and we're going to arrive at your first set of drugs early here because they are actually also endogenous ligands. So let's look at these compounds. You see in your body right now, in your periphery, you have norepinephrine and epinephrine being major neurotransmitters in this system. If you also look under here, and I'm going to show you on this side of the notes, in red are going to be the drugs. So drugs 6, 7, and 8 on your model drug list are actually dopamine, norepinephrine, and epinephrine, I believe. Double check me on that, but I think they are. So, there they are. There's your first group of compounds. These compounds, dopamine, norepinephrine, epinephrine. And you guys are thinking, okay, those are on my model drug list, but they are also endogenous ligands, right? You'd be exactly correct. You'd be exactly correct. And that's not the way it is in this class usually. Usually a drug is only an exogenous ligand. But here, these compounds are actually both. You can intravenously administer all three of these compounds, and you will potentially do that. So, why do I mention these three compounds to you? Because remember, from your physiology, in the course of catecholamine synthesis, as is shown for you in the top right-hand corner of this slide, you remember that you go from tyrosine, right, to dopa, to dopamine, norepinephrine, and epinephrine, right over here. Remember this synthetic pathway right here. And these three compounds right here, remember dopamine is hydroxylated right here to norepi, and then norepi is methylated to form epinephrine. But that's not the point of the discussion I want you to focus on. I just want you to focus on those compounds being critical, okay? Critical endogenous catecholamines. You guys all know that. Well, why then? Why are they so critical? And why in your body right now are those compounds really important to you? Well, remember, dopamine, especially in your brain, right, has a really dominant effect on your CNS and what's going on there. But norepinephrine plays a major role in your vasculature, right, and other parts of your body as well. So it's critically important for you to think about. If you look over here to the bottom side of the picture, what you'll see is that normally, and we're going to talk about this a lot during the first hour, remember, you have a presynaptic neuron and you have a postsynaptic side over here, right? And the neurotransmitter is released, it crosses, interacts with receptors on the other side. That's what this picture right here is designed to show you. You see the sympathetic neuron right here, guys. The neurotransmitter that they're going to focus on right there is going to be norepi. You see norepi, right? Norepi is NE right here is released from this presynaptic side. It crosses the synaptic region, and on the other side, on the tissues, it interacts with these specific adrenergic receptors right here. That's pharmacology, right? That's what we talked about. Compounds crossing, interacting with receptor, and then producing some sort of response that you see right here, shown for you right here. Now, what is critical to our discussion, though, is that on those tissues are certain receptors, and they are shown for you here on the postsynaptic side as being the alpha-1 receptor, okay? the beta-1 receptor and the beta-2 receptor. And you see them listed for you right here, and I'll try to follow on the pointer so you guys can as well. You see the alpha-1, beta-1, and the beta-2 receptor. So think about it. The norepinephrine was produced, right? It crossed the synapse and then goes over and interacts with those receptors and produces some sort of response. That's again what's happening in your body right now. Now, what we will do sometimes in pharmacology, oftentimes, of course, based on the topic, is that we will introduce drugs right here which could potentially mimic this system, right? You could intravenously administer norepinephrine, correct? You could absolutely do that. You could intravenously administer norepinephrine. You could do the same for epi. And you see these drugs now travel in right here, then they can interact with the receptor and they can produce a response. Most of the time in this class, when I give you a group of drugs, it's that latter discussion. You guys are going to be administering the drug. The drug is not an endogenous compound, right? But in this case, what you have to wrap your head around and think about is, okay, the body already is producing these catecholamines, but if they are produced in maybe lesser amounts, maybe I need to give some more to help. You know what I'm saying? So that's what I really want you to focus on and kind of think about. Now, one of the things that's important to our discussion this morning is that remember what the fate is of that norepinephrine. I told you it's going to travel across and interact with the receptor, right? And that would be all good. But you'll notice right here that the norepi can also do other things as well. It can be taken back up into that presynaptic nerve terminal, and you see it written right here, uptake, or it can be broken down and terminated, okay, by the enzymes that you see right there. Catechol-O-methyltransferase is shown for you right here as COMT. That is what actually degrades that compound in the synaptic region. The degradation of norepinephrine in the presynaptic nerve terminal is in the form of monoamine oxidase, or MAO. That is the reason that most of your norepinephrine, as you can see in this picture, is present in granules. Because if it's not in those granules, you guys remember, it's not protected, right? It's not protected from monoamine oxidase. So, this is kind of an overall summary of the synthesis and the release of this compounds. But one other thing I didn't mention for you, you guys are probably looking at it right now on this slide, is the good old alpha-2 receptor. Remember, I told you that norepinephrine is going to travel across the synapse, interact with the alpha-1, beta-1, and beta-2 receptor, right? But what I did tell you, because I think this will probably be the confusing part of our first hour of discussions, or maybe I was trying to hide away from it just a little bit, is the good old alpha-2 receptor. Now, in truth, the alpha-2 receptor is located on this side over here, along with the alpha-1 receptor. But I want you to circle it being right here, or this presynaptic receptor. Does everybody follow where I'm pointing to? I want you to realize, because in veterinary medicine, you are going to take great use of this receptor. It is found presynaptically, okay, on the neuron which is going to release the norepi. And what is the function of the alpha-2 receptor in the body? What's it doing there? It's a negative feedback, right? It really regulates the release of norepi. So if norepinephrine interacts with the alpha-2 receptor, it tells that presynaptic neuron that, hey, there's plenty of me out here, let's not release anymore, okay? So it's a negative feedback receptor. And the reason I tell you that is because, have any of you used compounds like xylazine or medetomidine to sedate an animal, okay? We use it a lot because we sneak cats into our MRI facility late at night to image them sometimes. And so in order for us to do that, we wait for the last human to leave. This is a true story, guys. You're hearing it from me. So the last human to leave, we have our cats lined up out in the hall. We walk them into their local areas. It's so funny. I'll show you all this sometime. And then when we get them inside, we give them a shot of medetomidine so we can sedate them. And we have about 20 minutes from that point to get them in the machine, image them, and get them out, get them back in their carrier. The reason that drug works like that for us, and it's a great compound, is because once we administer it just like this, it enters this body, the body right here, interacts with this alpha-2 receptor, and what does it tell that presynaptic nerve terminal to do? Stop releasing the norepi, right? So the cat views it centrally. Remember, centrally norepi is responsible for arousal and wakefulness, and you see them slowly go to sleep. And I've also watched them slowly awaken in the MRI before. So be aware of that now. So anyway, well, I will talk to you about those drugs in just a minute, but I want to kind of give you an example of that. Alpha-2 is very important. Alpha-2 will confuse you though. Okay, hold on, sorry, I got it locked up on me for just a second. Okay. So, let's look at the receptor interaction that I showed you the bottom right-hand side of that picture. Okay, so the norepinephrine has been released. I mentioned to you that it's going to travel across, right, interact with the alpha-1, beta-1, beta-2 receptor. This slide shows you some specifics about that so-called adrenergic receptor interaction. What I want you to think about again is when the norepinephrine binds to that receptor, that is a switch, that is activation. Just like I told you in class I guess it was last week, it's an agonist interaction. So when the norepinephrine binds to the receptor, something is going to happen. And what happens is those signal transduction events that we talked about. But those signal transduction events are different depending upon the receptor that you're talking about. So let's look and see what that means. In the case of the adrenergic receptors, you should know that they are G protein coupled receptors. Remember last week I told you there were 4 types, right? There were ion gated, there were G protein coupled receptors, there were tyrosines, and then there was in the nucleus DNA related receptors. There were 4 superfamilies. The superfamily here are going to be G protein coupled receptors. Okay, so look at what happens. In the case of alpha-1, it is